So we're going to go ahead and move on to our next session, which is more treatment options. And we're going to be moving further down the GI track and talking about the small and large intestine and also working into the pelvic floor. So,
well, great. And so in this next session, we're really excited to hear from a number of world experts. The first talk is going to be on pharmacological and surgical treatments for small and disorders of the small and large intestine. And it's going to be given by a good friend of ours, Dr. Brian Lacy, who's a senior consultant and professor at the Mayo Clinic in Jacksonville. Brian is also the recently retired co-editor-in-chief of the American Journal of Gastroenterology and on the board of trustees of the college, as well as being so involved with IFFGD. The second talk is going to be on current novel treatment options for pelvic floor disorders. And that's going to be given by Satish Rao. And Satish is the head of the Pelvic Floor Center at the Medical College of Georgia in Augusta, Georgia, and really an international expert on disorders of the pelvic floor. And then finally, we're going to hear about behavioral treatments for gastrointestinal disorders by Dr. Lori Keefer, who's at Mount Sinai University and really widely regarded as the grand dame of behavioral therapies in the United States. Many would argue in the world, actually. So we're looking forward to hearing those talks.
Absolutely. We hope you enjoy these, and we'll be back with you on the break to discuss.
Welcome. My name is Brian Lacy. I'm professor of medicine at the Mayo Clinic in Jacksonville, Florida. I'm delighted to be a part of the IFFGD 30th anniversary lecture series. And over the next 15 minutes, I'm going to discuss pharmacologic and surgical treatment for the small and large intestine. Recognizing that there have been a variety of other really great lectures, I will not really be focusing on the diagnosis of these disorders, nor will I cover dietary interventions. So my objectives today, to review the most common functional motility disorders of the small and large intestine. I'm going to discuss current pharmacologic treatment options and discuss the limited surgical options available. The topics we'll cover today specifically will be irritable bowel syndrome, or IBS, small intestinal bacterial overgrowth. Some patients refer to this as SIBO. Other disorders of the small intestine, chronic bloating and distension, chronic idiopathic constipation, and colonic inertia. Let's begin with IBS, or irritable bowel syndrome, because that's really the best studied and probably the best understood disorder of gut-brain interaction, also called functional bowel disorders. And when I think about the treatment for IBS, treatment really depends upon disease severity. So as a patient, some patients have kind of mild symptoms, meaning that the symptoms are present, whether it's pain or diarrhea or constipation or alternating constipation diarrhea. And of course, bloating is so common as well. But if those symptoms are not burdensome, are not affecting your home life, social life, professional life, that for many patients, simple interventions, including a great explanation about what IBS is, reassurance that this never turns into anything bad or dangerous, using over-the-counter medications, and maybe some lifestyle interventions such as changes in diet, better sleep, and physical exercise, will all that's required. However, patients with moderate or more severe symptoms generally require pharmacologic treatment, meaning prescription medications, and may also require other treatments involving coexisting anxiety or depression, which frequently goes hand in hand with any disorder that's chronic in nature. When I think about medical treatments for IBS with constipation, when the constipation symptom is predominant, there are a number of options available. I won't cover probiotics or complementary and alternative medication, abbreviated as CAM, or osmotic agents, because they've been covered elsewhere. I'm going to focus on the 5 medications approved by the Food and Drug Administration for the treatment of IBS with constipation. The first group are those that we call secretagogues, and they're called secretagogues because generally these three medications, when they work in the GI tract, cause the GI tract to secrete fluid into the GI tract, which increases transit through the GI tract. The first agent is lubiprostone, also sold as Amitiza. This accelerates small bowel and colon transit. It's approved for the treatment of both men and women with chronic idiopathic constipation and women with IBS and constipation. Speak to your doctor about this medication. It's safe and it's effective. It comes in 2 different doses, 8 micrograms and 24 micrograms. Linaclotide is a medicine called a GCC agonist. It acts on the guanylate cyclase C receptor. It too improves movement through the GI tract. It also has been shown to act on the sensory nerves in the GI tract to improve abdominal pain. It's approved again for both IBS-C and for chronic idiopathic constipation, and it comes in 3 different doses, 72, 145, and 290 micrograms. The new kid on the block is plecanatide, sold as Trulance. It comes in 1 form only, 3 milligrams, and it too is approved for both chronic idiopathic constipation and IBS with constipation. The other 2 agents both begin with T. One is tenapanor, the other is tegaserod. Tenapanor acts quite differently. It acts on a different receptor involving the sodium hydrogen exchanger. There's very good data from a large randomized controlled trial showing benefits compared to placebo. It was approved by the FDA in September 2019. Distribution has still been a little bit tricky, so it's a little hard to get, but it is available and it's very effective for IBS-C symptoms. And then tegaserod acts on the serotonin receptor system. In this case, it acts on the 5-HT4 or the type 4 serotonin receptor, and it stimulates that receptor to improve motility in the GI tract and improve visceral or gut pain. There's a bit of a storied history where it came out and then was withdrawn voluntarily due to some safety concerns, but it was reapproved for the treatment of IBS-C in women less than 65 years of age without a cardiovascular history. And this is very safe in that population. It's sold in a 6 milligram form. Let's shift gears now and talk about medical treatments for IBS with diarrhea. And I'd like to show this slide because it shows there are so many different treatment options. Once again, in the interest of time, because the topics are covered elsewhere, I won't talk about diet or probiotics or some of the simpler agents. I just want to mention that the 5-HT3 antagonist, alocitron, that acts on the type 3 serotonin receptor. Very good data from large randomized studies showing it improves urgent diarrhea, it improves urgency, it improves pain and bloating in patients with IBS and diarrhea. It's approved by the Food and Drug Administration for women with symptoms that persist despite using either dietary interventions or Imodium, loperamide. The gut-selective antibiotic rifaximin has been shown in 3 very large randomized placebo-controlled trials to improve IBS with diarrhea symptoms, including gas, bloating, urgency, diarrhea. Finally, eluxadiline is sold, and this improves IBS diarrhea symptoms. It acts on the opioid receptors in the GI tract to slow the GI tract a little bit, but not causing horrible constipation, and it improves symptoms of urgency and diarrhea as well. In terms of eluxadiline, if you've had your gallbladder removed or you have had a history of pancreatitis, you should not take that medication, but I am sure your healthcare provider will know that. Let's talk about small intestinal bacterial overgrowth, a common question that comes up from patients when they have symptoms of gas and bloating. And the treatment for that involves first thinking about the underlying disorder. We look at the medication list because some medications slow small bowel transit. By eliminating those medications, we can increase transit, get rid of the underlying problem, and thus improve symptoms of bacterial overgrowth. And then sometimes, in some patients, we accelerate small bowel transit to improve symptoms. Or we can target the bacterial overgrowth directly and use antibiotics. I'm going to come back to that in a second. In the occasional patient, long-standing bacterial overgrowth, leads to nutritional issues, and your healthcare provider will want to investigate that and treat appropriately by replacing fat-soluble vitamins and also B12 and calcium and magnesium. Which antibiotic might you want to use for small intestinal bacterial overgrowth? This slide shows treatment options available. I wish I could tell you that one was significantly better than the other, but there have been no head-to-head comparisons. And thus, it's really important that you have a nice discussion with your healthcare provider about the risks, the benefits, and the cost of each of these agents. What about small intestinal dysmotility and chronic intestinal pseudoobstruction? If you've listened to some of these other lectures, you're now comfortable with those topics. The most common cause of small bowel dysmotility or slow transit is the connective tissue disorder scleroderma. Other connective tissue disorders can cause symptoms including SLE or lupus or dermatomyositis or polymyositis, but those myopathic disorders are much less common. Treatment options, we could think about a prokinetic agent, and a prokinetic agent is a medication designed to increase transit through the GI tract. Generally, we think about the 5-HT4 agonist, coming back again to the medications that act on the serotonin system. 5-HT4 stands for serotonin, and this acts on a type 4 receptor, so we use prucalopride. This is sold as a prescription as Motility, or as I mentioned, we can use Tegaserod, that's sold as Zelnorm. Both of these agents are safe and effective. Some patients require injections, and that's octreotide, and that's the one medicine that's been tested to really show that it helps small bowel transit. Can be very effective, although many patients don't like to take shots. As I already mentioned before, sometimes we use these agents called secretagogues, such as linaclotide or plecanatide, sold as Linzess or Trulance, to accelerate small bowel transit. And occasionally we use medications that block acetylcholinesterase. That's the enzyme that breaks down acetylcholine. And we may use pyridostigmine or rarely neostigmine, because by blocking that enzyme, it accelerates small bowel and colon transit. What about the problem with bloating and distension? This is so common and is found in patients with IBS and chronic constipation and bacterial overgrowth and even functional dyspepsia and gastroparesis. When I see a patient and I start thinking about the pathophysiology of bloating and distension, I like to think about three major processes: things that stretch the bowel wall, causing tension and discomfort. I think about being too sensitive in the GI tract, this augmented conscious perception of wall tension. And I think about an abnormal viscerosomatic reflex. That's an abnormal gut muscle wall reflex. Let me go through those briefly. When I think about patients who have increased bowel wall tension, what treatment options do we have available? The first is dietary modifications. I'm sure you've heard this before from other lectures. I won't go through that, but it's nice to see this on the slide for your own knowledge. We can modulate the microbiome. So as we've discussed for SIBO in the past, we may use antibiotics. Some providers use probiotics. I generally don't do that because the data is not very strong. And many times probiotics makes bloating worse. Or as we've already mentioned, we can accelerate gastrointestinal transit using a prokinetic agent or a secretagogue. If I believe the underlying physiology and pathophysiology leading to gas and bloating is a visceral perception, remember that many patients with disorders of gut-brain interaction are overly sensitive in the GI tract. We have a host of options. We may use a very low dose neuromodulator, such as a tricyclic antidepressant. Don't think we're treating underlying depression. What we're using is to block these pain receptors, and very low doses can be effective. We may use other antidepressants. There are two big categories. One are called SNRIs. Duloxetine is an example, or we may use SSRIs, and those can be helpful if you have some anxiety as well. Other agents are available, such as gabapentin and pregabalin. Of note, opioids should not be used in any of these disorders because opioids or narcotics will slow the GI tract, make symptoms worse, and it's very easy to become addicted. Finally, that big category of this abnormal viscerosomatic reflux. Viscero means your gut. Normally, when gas stretches the small intestine or colon, normally, if we look at the upper right-hand corner of the slide, your abdominal wall muscles contract to keep your belly flat, and your diaphragm, your breathing muscle, ascends to increase the size of your abdominal cavity. But some patients actually have a wiring problem. They have an electrical problem in their GI tract where this reflex is reversed. And what happens, as shown in the right lower corner of the slide, is the diaphragm abnormally descends. That makes your belly cavity smaller and your abdominal wall muscles inappropriately relax. And that's why you get such marked distension. How is that treated? We actually teach patients diaphragmatic breathing, and this slide illustrates how you can do this. Sometimes we use biofeedback. By the way, there are some great YouTube videos on diaphragmatic breathing, and you may want to look at those. What about chronic idiopathic constipation? Chronic means that symptoms started at least 6 months ago, and they've been active in the last 3 months. Treatment options, I briefly mentioned osmotic agents, and I know you've heard other lectures about something like polyethylene glycol, sold over the counter as Miralax or Glycolax. We've discussed the secretagogues. They increase fluid secretion into the GI tract and thus increase intestinal transit, lubiprostone, linaclotide, plecanatide. And we've discussed these prokinetic agents, these 5-HT4 agonists such as prucalopride and tegaserod. All are very effective and can be very helpful. Lastly, what about that uncommon patient with colonic inertia? These are generally women. Men can occasionally have it, but much less common. And these are patients who may have a bowel movement every 4 weeks or 6 weeks. If you fail medical therapy, and that's the key phrase, if you fail all of these therapies for weeks at a time, and if you do not have a pelvic floor disorder, pelvic floor dyssynergia or a large rectus-seal or something else, that should be carefully investigated. Then some patients respond to sacral nerve stimulation as shown here. That's done only at specialized centers. The data is okay, in my opinion, not perfect, but okay. And rarely, when symptoms are so severe and patients have failed every single agent we have available, and they do not have a pelvic floor problem, then we may recommend removal of the colon. But remember, that's really the last thing that should be done. And once the colon is removed, it's irreversible. And of course, for most patients, then when that's done, they have frequent bowel movements, sometimes 6 to 8 per day. So there is a trade-off. As we wrap up here, as an audience, I think we all recognize that these motility or functional disorders, now called disorders of gut-brain interaction, are common. They affect about 40% of the population overall. Fortunately, in this day and age, multiple treatment options are now available. And when you see your healthcare provider, discuss these individualized options, because really it depends on who you are, what your symptoms are, what tests you've had to date, and what treatments you've had. One size does not fit all, but fortunately, again, we have so many different options that there's a treatment out there available for you. Thank you so much for listening today, and thank you for participating in this great IFFGD lecture series.
Hello, I'm Dr. Satish Rao from Augusta University. Thank you so much for inviting me to be here with you. It is an honor to speak in Nancy Norton's celebration symposium. Nancy is a very good friend and has been a tireless worker for patients with bowel disorders and functional bowel disorders and fecal incontinence. So it is indeed an honor to join all my colleagues to honor this distinguished colleague. The title of my presentation is Current and Novel Treatment Options for Pelvic Floor Disorders. These are some of my disclosures. The objectives for my talk are to discuss with you what is the pelvic floor, what are the common pelvic floor disorders, and discuss advances in the evaluation, diagnostic workup, and treatment of two common pelvic floor problems: constipation with dyssynergic defecation and fecal incontinence. Now, this is the pelvic floor. All right, what do we mean by the pelvic floor? Well, this bone, or the hip bone, is called the pelvis, and the structures that are housed inside the bone is what we call as pelvic floor structures. And problems that arise from these pelvic floor structures lead to pelvic floor disorders. Now, if you stand up a person and look at the individual sideways and you really do a section, this is how the anatomy looks. Here is the front, here is the back. This is the little bit of the backbone or the sacrum bone. And if you go from front to back, this is the pubic bone. The first organ in the front is the urinary bladder. The next organ in a lady, you have a uterus and the vagina and the vaginal opening. The third organ is really the rectum and the anus opening, and behind it are the bony structures. These are the principal components of the pelvic floor. What is its function? Well, the pelvic floor is an important organ in itself and performs a number of functions. First of all, with regards to bladder and bowel control, it facilitates passage of urine and stool. It is an important organ for sexual function, an important organ for breathing because it's part of the diaphragmatic breathing process, and a very important organ for pregnancy and childbirth. Therefore, multiple key functions are performed by the pelvic floor. Now, what are the very common pelvic floor disorders? We have a number of disorders that are part and parcel of the pelvic floor. For example, a person with stool leakage, otherwise called fecal incontinence, a person with difficulty with evacuation or bowel movement, also called dyssynergic or incoordinate defecation, patients with anal pain caused by a fissure, patients with a condition called solitary rectal ulcer syndrome, where they have an ulcer in the rectum and they bleed and excessively strain. There is pelvic pain, there is rectal prolapse, there is rectocele, which is like a small protrusion in the front of the rectal wall. There is excessive movement of the perineal muscles on the wall so that there is weakness and descent. There is anorectal pain, also called levate ani syndrome or proctalgia fugax, and there are hemorrhoids. Some of these, some of you may already know, some of these, some of you may not know, but this is just a list of the very common pelvic floor disorders. But for time purposes here, we will only focus on the two important aspects, which are the more common and more difficult to manage and treat problems, which is constipation with dyssynergic defecation and stool leakage. So let's talk about constipation. A very common problem, affects up to a quarter of elderly population, but about 15% of the younger population. More prevalent in women than men. It leads to about 2.5 million physician visits per year. More than $1.4 billion of over-the-counter laxatives are consumed annually in the United States itself, not globally. Now let's talk something very important here. We as physicians, unfortunately, speak a language which is alien to our patients. And it is very important that physicians and patients connect with the right language so that we can understand our patients. Now, this is something that I've been teaching for the last 25 years and will continue to do so. But if you are a patient listening to this, please be patient and try and help to make your physician understand and make sure they truly understand your problem. Because many times people use certain terms that are misunderstood. Here, patients were asked a simple question, what is constipation? And you can see 27% of patients thought it was having a bowel movement every 2 days or less frequently. None of the physicians believed that was the case. Having a bowel movement 3 days or less often, 25% of patients felt this was so. About a quarter of the physicians believed. But look at this. Having a bowel movement every 4 days or less often was reported by 13% of the patients, but almost half the physicians believed that this was their definition of constipation. Look how disconnected we are when compared to what our patients are reporting. Hard stools alone, quarter of the patients believe that's constipation. Only 6% of the physicians thought that was constipation. So there is a major disconnect between us physicians and you patients, and we need to connect better. And this really, the onus is more on the physicians, but I just want you to become aware of this. So today, how do we define constipation? We have now learned that constipation is not a one problem, one symptom, one mechanism disorder, but it is multiple symptoms. And we have 6 important symptoms that we now use. And if a patient has at least 2 of these symptoms for 3 months or more, then we say that the patient has constipation. The symptoms are, number 1, excessive straining, hard or lumpy stools, feeling of incomplete evacuation, a feeling of blockage, or use of physical digital maneuvers to disimpact or remove stool, or stool frequency of less than 3 bowel movements per week. Any 2 of these makes you constipated. Let's turn to this interesting case story. A 51-year-old school teacher came to see me with a 5-year history of constipation. Began during college days. Now bowels move once every 1 to 2 weeks. So severe constipation, hard stools, pellet-like stools, only after fleet enema, suppository and laxatives. She uses digital maneuvers and describes excessive straining, a feeling of incomplete evacuation, and occasional bleeding. She tried a number of over-the-counter laxatives, including prescription laxatives such as linaclotide and Miralax or PEG. None of them gave relief. Now, this is a very classical presentation of a patient with dyssynergic defecation. So when I see patients like this, we use a number of tools to actually help. First is really take a good history, just like I've given you, then try and perform a careful, meticulous digital rectal examination. I know many of you are shy of this kind of examination, but this really informs us significantly about some of the mechanics that people may be using. And then we use various tools to confirm the abnormalities we pick up in the rectal examination. And one thing that we've also learned recently is there is a disconnect, as I just shared with you, between patients' history that they provide and the physician's ability to extract the history from the patient. One way to bridge this gap is by using prospective stool diaries, or more recently, we have developed with the help of a company some apps. Here is an app for constipation, and here's an app for fecal incontinence that patients can keep. These are just like 10 to 12 questions. It takes about 2 minutes to complete the app, and this kind of an app record will provide an accurate recording of bowel symptoms, removes any bias, and provides a very good way of understanding the patient's problem. So I would encourage all of you to use it. With regards to testing, we have a number of tools. Anorectal manometry, we put a probe in the rectum with pressure sensors, endosonography is an ultrasound test, nerve function test, and a balloon expulsion test, etc. These tests can be very useful in really providing us with accurate information. Here are some of the various screens on the app. For example, stool consistency on a Bristol scale. Did you have a bowel movement? Did you strain? Did you have to use finger stress stooling? And you just have to answer yes or no, and you can generate a table and a report at the end of it. We also compared in a scientific study how good is the app, and also looked at its functionality. Suffice to say that the app compared very favorably with the paper, and about 58% of patients preferred the app to the paper form of diary. So when we look at patients with constipation, we broadly categorize them into 3 common groups. IBS with constipation, where pain or bloating is an important feature, along with altered bowel habit. Slow transit means the colon has become lazy, not able to move stool. Evacuation disorders, multiple disorders, but dyssynergic defecation is the key, where the act of moving stool out of the rectum has become incoordinated, leading to difficulty with evacuation. If you identify dyssynergia, a common pelvic floor disorder, what can you do? Well, the best treatment is what we call as biofeedback therapy, a technique of conditioning and retraining the mind and the body, particularly the body, to normalize bowel movement. And these are the principles of biofeedback therapy. First, we teach them diaphragmatic breathing exercises. Then we teach them posture and how to relax the pelvic floor. If patients have impaired sensation, we improve this by sensory training, eliminate sensory delay, and lastly, we provide simulated stools to facilitate expulsion of this in the laboratory. This kind of a teaching session takes approximately 1 hour, and we do this once a week or once every other week, and usually 70% of patients are successful in correcting their abnormal behavior. The patient I just described to you had classic dyssynergia, and after 5 sessions of training, now she can generate a good push, and then nicely relax in the anal canal, showing normal coordinated defecation. And that is the way I would normally manage a case with dyssynergic defecation. Let me switch gears and talk about another case. A 42-year-old lady, gravida 3, para 2, first developed fecal incontinence 2 months after her first delivery, had her second baby, and then this leakage became worse. Now, when she's come to see me, she reports 2 bowel movements a day and about 4 to 8 leakage events per week for the past 10 years. She can sense the stool coming out, sadly cannot stop it. Sometimes she's walking in a store and this happens, and this is really very embarrassing. Also has leakage of gas, no urinary incontinence, a back injury. She has some hypothyroidism. She tried taking psyllium as advised by her doctor, she tried taking antidiarrheals such as loperamide. They have not afforded any relief. So what can you do for this patient like this? Now, fecal incontinence is a devastating, embarrassing problem that affects 14% of the American population. A very recent study of surveying 71,000 Americans, 1 in 7 Americans suffers with this problem. It is slightly more common in women and significantly more common in older age individuals. So why do people develop this, and what are the predisposing factors? Now, if we have urgency and diarrhea, all of us are potentially at a threat of developing stool leakage. Fortunately, we are not, but in a FI patient, this can be a problem. As we age, our muscles and nerves age and potentially predispose us to us. But one of the important factors, which was also a cause in the patient that I just described, was obstetric injury, unfortunately caused by the use of forceps during the birth of baby. This somewhat traumatic delivery causes significant damage to the pelvic floor, including muscle and nerve damage. And in this case, there was damage to the muscle that was torn, leading to this. Patients who unfortunately have a spinal cord injury where the nerves have been compromised, although they may recover from the injury, the nerve damage may persist, giving rise to both urinary and stool incontinence. Older patients and sometimes young kids also, there is significant retention of stool. It's called fecal impaction. And then there is overflow leakage, which is another common reason. But what I think is the most important message here is fecal incontinence is rarely caused by one mechanism. In 80% of patients that we have studied, we've shown more than one mechanism, such as muscle being torn or nerve being damaged or rectum not able to sense, or rectum is too sensitive, or there is inability of the rectum to hold stools. Rectum is a reservoir for stool and can expand itself. But if that expansile ability is compromised, then unfortunately, a patient can have leakage. Clinically, we subdivide them into 3 types. Passive means, like this lady, walking in a store cannot sense stool and it's leaking. Or you have an urge to go, but you can't make it to the restroom, urge incontinence. Or you have a normal evacuation and then you feel some wetness, and that is because small amount of stool has seeped. And these have different mechanisms, and that is what physicians will be interested in finding out and treating. Again, in terms of evaluating them, we talked about the constipation app. Here is the FI app, which also asks if you've had a leakage, how much of leakage you had, and so on. And this can be very useful in documenting the story. Manometrically, when this is a healthy manometry, you can see when the person squeezes, very nice red here. Whereas in a patient with stool leakage, there's a big gap because the muscle is torn and defective. Ultrasound, intact muscle here. And here you can see, instead of being like a round, it is a crescent because the muscle is torn in the upper part. Some new tests that we've developed are for studying nerve function non-invasively. We can now apply a magnetic coil to the lumbar region or the sacral region, and then we can use a neurophysiology recorder and a magnetic stimulation device to nicely study the neurological function. Here is an example of a healthy individual with normal conduction and a patient with fecal incontinence having very prolonged conduction of the nerve function. In terms of treatment of stool leakage, well, fiber supplementation and antidiarrheals can be helpful in about 15 to 20% of patients, along with Kegel exercises. But in the vast majority of patients, this is not successful, and they will need specific therapy. One of the most effective specific therapies is biofeedback therapy, where we teach the patient to strengthen the anal sphincter muscle, improve sensation, and improve coordination, and those with dyssynergia to correct that. Here is an example. Here's a patient. We ask the patient to squeeze. Here is the muscle pressure from 0 to 100 millimeters. You can see that the person can squeeze up to 80, but only lasts for 1 or 2 seconds. It drops a very weak squeeze. After 5 sessions, now the same person, very good squeeze up to 100 and sustain the squeeze. This is what we can achieve with biofeedback therapy. In addition to this, There are some other more surgical procedures. Dextranomor injection is an injection which is inserted just into the anal canal. It forms like a nice buffer and forms a protective coat inside the anal region. Surgeons will do sphincteroplasty. If the muscle is torn, then you can bring the muscle edges together and suture it up. And there is sacral nerve stimulation, which is like a pacemaker to the sacral nerves, which stimulates the muscles and improves stool incontinence. And in some selected cases, we may have to do a bag or a colostomy, especially in those with spinal cord injury, as this is problematic. There are some new devices, such as that has become available. We have just done a control study with this device, and we found this to be very effective. Lastly, I want to touch base on a brand new treatment called TNT, or translumbosacral neuromodulation therapy. We've identified that 70% or more patients with stool leakage have nerve damage. Therefore, in these patients, we can apply a simple magnetic coil in 4 regions in the back, as you illustrated in this patient. And this magnetic energy flows and stimulates the nerves. And the nerves have a unique property called neuroplasticity. In other words, nerves have an ability to regenerate, regrow, and reconnect. So we capitalize on this property of the nerves. Very few parts of a body can do this, but nerves can do it. And that leads to improved connectivity of the nerves, leading to improved function and improvement in stool leakage. Does it work? Yes. In our pilot study, which we reported last year, 91% of patients who received 1 Hz therapy improved, 36 and 55% in the other treatments. So in summary, my friends, first of all, thank you for listening. Pelvic floor disorders are very common. It affects 25% of population, as I mentioned. Detailed history, physical and digital rectal examination is important. Electronic stool diary and apps provide an accurate history and severity assessment. The two most common problems, dyssynergic defecation is very common, missed by most physicians. So it is important to bring this to your doctor's attention. Manometry, balloon expulsion tests provide accurate diagnosis. Biofeedback is the preferred treatment. And hopefully in the future, home biofeedback will revolutionize this treatment approach for many of us. Fecal incontinence, a multifactorial problem. There are wonderful diagnostic tools. Ideally, if you can understand the mechanism and tailor the treatment to the mechanism, that will lead to greater success in management of the patients, including lifestyle measures, antidiarrheals, biofeedback, selected cases surgery or SNS, and novel treatments such as home biofeedback or translumbosacral neuromodulation therapy. I hope you found that very useful, and hopefully this will help you get better care, and good luck for all my patients. Thank you.
Hi, I'm Dr. Lori Keefer, and I am a GI health psychologist and professor of medicine and psychiatry at the Icahn School of Medicine at Mount Sinai, and I'll be talking today on behavioral treatments for GI disorders. So today I'm going to answer 3 questions. 1, why do we use behavioral therapies in the management of GI conditions? 2, what are some of the brain-gut psychotherapies that may help me? And 3, how do I go about finding somebody in my community if I'm interested in it? So first, why do we use behavioral therapies in the management of GI conditions, right? These are medical disorders, they're not psychological conditions. So why would we recommend a behavior therapy? First, we know that GI conditions, especially because they are unpredictable and uncomfortable and stigmatizing, really affect patients' well-being, and many patients need support. Secondly, GI disorders are some of the most stress-sensitive disorders. Even people who do not have GI conditions experience symptoms under stress. And third, the gut-brain axis is really responsive to the brain-based interventions as much as it is to the gut-based ones. So GI disorders clearly affect more than our guts. Many patients report a wide range of emotional and physical symptoms associated with their condition, including things like pain and shame and stigma and sadness, loneliness, isolation, loss of potential, fear of symptoms, fatigue, medical trauma, sadness, worry. All of those things are part of that experience of having a chronic GI condition. Secondly, GI conditions are stress-sensitive disorders, and we know that stress affects the gut-brain axis, as well as the gut-brain microbiome axis, which can in turn affect concentration and emotions. Secondly, early life stressors that patients have can sometimes affect, even as children, the development of their gut's nervous system and how their body reacts to stress in adulthood. So some people might be predisposed to being stress sensitive in their GI tract. Furthermore, what we do when we are stressed may also make our symptoms worse. People might eat more than usual or less than usual. They might increase their alcohol intake, worsening their heartburn and reflux. They may get less sleep, less exercise, or eat things that bother them. Stress may also increase the amount of air that we swallow, causing gas and bloating during the day. It can increase muscle spasms in the intestine. And then finally, I would just say that gastrointestinal symptoms themselves are stressful and sometimes breed themselves. One thing that I often recommend to my patients, and many of my gastroenterologist colleagues do as well right in their visit, is to teach diaphragmatic breathing. More than 50% of US adults actually have chest breathing. And even though our lung capacity in our lower lungs is where most of our air can be harnessed, we often don't breathe with that belly that we could be doing better. So because our disorders of gut-brain interaction are so influenced by the sympathetic nervous system, deep breathing allows us to sort of activate the opposite, the antidote, the parasympathetic nervous system. We know that GI conditions are often particularly beneficial in diaphragmatic breathing. It increases time in that rest and digest mode. And so many patients who practice this breathing feel that their GI tracts are more efficient. We know that it can also improve gastric accommodation after meals. So if you have dyspepsia or gastroparesis, it may be helpful to breathe for a few minutes after, during or after a meal. We also know that diaphragmatic breathing can improve the pressure gradient at the lower esophageal sphincter. So if you have reflux or if you have rumination syndrome, there are definitely techniques that you can use with your diaphragmatic breathing to help that. We also know that diaphragmatic breathing decreases bowel urgency and cramping, fear of incontinence or vomiting. And even when you're sitting on the toilet and anticipating discomfort from having a bowel movement, breathing can really kind of offset that process. So I'm a big fan of breathing, and many of your GI doctors have also been trained in how to teach you to do that. So be sure to ask. Now, brain gut psychotherapies are a little bit different than what you might see in regular therapy in the community, and I wanted to spend most of my time talking about that. So brain gut psychotherapies are targeted behavioral interventions that have been adapted or personalized to really reflect their impact on the underlying drivers of your GI symptoms. So brain gut dysregulation, basically. And there's growing evidence from neuroscience and brain imaging research that these therapies do indeed target the very specific, either cognitive, or emotional, or behavioral factors that are associated with the way the brain and the gut communicate in that bidirectional way, including things like an overactive nervous system, or fear conditioning, or pain catastrophizing, or hypervigilance, or overattention. So when I talk to my patients about brain gut psychotherapy, I often describe what they're experiencing as a software problem, not a hardware problem. So the problem that causes many symptoms is that your brain is overworking. It's like having an app or a series of apps that are tracking your background location. They are constantly refreshing and they're draining your battery because they're kind of on in a setting that is inefficient. So when the brain is overworking, as in the GI conditions, it's often paying unnecessary attention to what's going on in the GI tract. And so that's one way in which brain gut psychotherapies might be able to help. And I'll explain that in a minute. And then the second example is that, alerts from your gut to your brain are supposed to be informative. They're supposed to tell you when you're hungry, when you're full, when you need to have a bowel movement, when you're stressed. But instead, many of the times, the alerts can actually be uninformative. They can be false signals, false alarms. So that would be the example of you picking up every single spam or robocall that comes into your phone instead of just answering from known callers. So I like to think about behavior therapies as sort of decreasing the number of apps tracking your location, so that your brain is not working so hard and letting your gut sort of do the heavier lifting. And secondly, reduce your spam and unknown callers by teaching you skills so that there are less concerns about knowing the difference between a real threat and a false alarm. I'm going to talk about a couple, the two primary therapies for brain gut. One is gut-directed hypnotherapy, which, for those of you who don't know, is a medical therapy, medical hypnosis, in which you are placed into a very relaxed and focused state using physical relaxation and guided imagery. And once you're in that state, so if you think of that initial relaxation state as an IV needle going into your arm, what you're, the really therapeutic piece is the dose that is put into that needle, right? It is the idea or the suggestions that are specific to your GI tract that are going to be the most effective ingredient of the intervention. And many of these therapies are offered over 7 to 12 sessions. There are some really straightforward protocols that can be provided by a hypnotherapist over 3 to 4 months. And there's home practice in between visits so that they can really kind of help you cope throughout the week and not just during your scheduled sessions. CBT, cognitive behavior therapy, is the other one that I highly recommend with the most data in GI conditions. It is a theoretical orientation that sort of understands that the brain and the gut become intertwined in unhelpful ways, often conditioned responses from having experienced symptoms, and patients end up developing behaviors and coping strategies that may have been helpful at the beginning of their disease, but no longer are. And so the GI CBT therapist can really help patients retrain the way that they think and respond and feel to their symptoms in a very collaborative, personalized way that can influence the ways gut sensations are even experienced in the brain. So here's an example. Let's say that a patient is on their way to go on a road trip with their friends. And they have the following thoughts. I'm worried that I'm going to have to stop to use the bathroom. I'm going to inconvenience my friends. I'm going to be embarrassed if I have to ask the Uber driver to pull over. Or if there's no place to pull off and I have to go to the bathroom, I might have a bowel accident. Now, this patient is not wrong necessarily that these things could happen, but they're making some huge assumptions that might not be helpful. They're assuming that it's definitely going to happen. They're assuming it's going to be catastrophic and embarrassing, that they have no control over it and they wouldn't be able to handle it. And so CBT might pose some different questions. What is the realistic likelihood that you're going to have to emergently stop along the way? What is the realistic likelihood that your friends would be upset that you're going to have a bowel accident? And even if you did, you wouldn't be able to handle it. And then the other side of that would, if it happened, let's assume it did, what would it be as bad as I think? Would your friends like you for who you are? Would you judge another person if something terrible like that happened? How much do you really have control over your bowel movements? And finally, is it really worth getting yourself worked up about increasing the likelihood that you actually do have a problem? So lastly, just to wrap up, I wanted to talk a little bit about accessing this GI behavioral care for any of those reasons, whether you're having trouble coping and have intense feelings about your symptoms and struggles, whether you are looking for stress management strategies because stress is very sensitive of your disorder, or whether you really are interested in a more comprehensive brain gut psychotherapy approach. The key to brain gut psychotherapy is that it works best when we, the therapists, are in contact with your gastroenterologist. And so it's really important that you have a doctor that you trust who can talk to you about your brain gut dysregulation and the factors that are really driving your particular symptoms, so that when you go to the therapist, to the behavioral person in your community, you're able to explain to them why you're looking for cognitive behavior therapy or gut-directed hypnotherapy or what have you, and that your GI doctor can communicate with them if they have any questions around your physical condition. And this is really, really important. The other challenge is obviously in identifying those suitable providers. And so here is a list of some places you might be able to find therapists in your community. And you can often filter by insurance and gender and those and location. But I wanted to point out that, it's not necessary to find somebody that has GI specific experience. Instead, you may want to just look for people who have language in their profiles about working with patients with chronic illness or chronic pain. Usually those providers have specific training in behavioral medicine, health psych, medical social work. Then you also can look for therapists who say that they do cognitive behavior therapy or solution-focused therapy or gut-directed hypnotherapy. And then if you find a therapist that you do like, who's like, what is IBS? What is GERD? What is gastroparesis? You can always refer that therapist to our Rome Gastro Psych group for training and consultation. So just to remind everyone of the key goals today is that GI conditions really affect well-being, and behavior therapies may help with coping and social support. They may also brain gut psychotherapies are very personalized and target brain gut dysregulation and GI symptoms. And finally, I didn't get a chance to talk about this, but in the future, there are a lot of other positive psychology interventions that may also be useful in promoting well-being with a chronic GI condition. Thank you.
Hello and welcome back. Thank you for joining us today as we are in our final day of the Norton Educational Series 30th Anniversary Edition. We just listened to some great presentations and really wonderful talk about the small bowel from Dr. Lacy, and then Satish Rao with the anorectal, and then Lauren Keefer with behavioral therapy. So we got some questions in from the audience on this session. So we're going to go ahead and talk about those. And the first one is really and truly about some of the terminology used with Dr. Lacy. And so Dr. Lacy mentioned some words that we did not define earlier this morning. So let's talk a little bit about, he used the word receptors, antagonists. Can you maybe talk to us a little bit about what that is?
It's hard to actually describe receptors in lay terms, but I guess the way I would put it is it's a part of the body, the tissue in the body that receives signals or from a stimulus. And if you act on that piece of tissue, that receptor, then it'll trigger a biologic or physiological or chemical reaction for something to occur. So if there is a medication that acts on those receptors, that specialized piece of tissue, then it'll create a reaction. If a medication blocks it, they're called antagonists, so against it. So it's agonist means it acts on it, and the antagonist blocks it. That means it'll inhibit, it'll block the effect that you normally would see when it gets triggered.
You know, a good way to think about this is a lock and key kind of analogy. So if you think about the chemical mediator like serotonin, for example, being the key and the receptor being the lock, the key opens the lock and then leads to a downstream physiologic effect. Maybe it's triggering motility, maybe it's having an effect on sensation. But if you think about the chemical and the receptor as a lock or as a key in a lock, that'll sort of help you to understand what's happening.
That's a really good way of putting it. So the agonist would open the door.
Exactly.
But a blocker would make sure it's shut.
Exactly.
It won't open the door.
Yes.
Okay.
Yeah.
Well, that is great.
Yeah.
Thank you so much. So much easier to understand that now, especially when you are talking to your healthcare provider and he's talking about these. That definitely be helpful. So let's talk a little bit about Dr. Rao's presentation, because we had a lot of questions about the apps. So he talked a lot about some of these apps that are out there that are great for constipation and the fecal incontinence. And so there are a lot of apps available. So how can a patient maybe go about knowing what is a good app, what is not a good app? And I know this is a long conversation. We don't have a lot of time, but just really quick and briefly, I know, Bill, you spent a lot of time working and researching in this area.
Yeah. So it's really difficult to answer the specific question you posed, the meaning like how do patients sort through this, because this is moving so quickly. Like Cecile, even like in the time that you and I have talked about this several times over the last few months. And even in that time frame, new apps are coming online. So what I would say is it's really important for the patient to look at the app and then determine whether or not the interface is user-friendly and easy for them to be able to actually impute their information, and also whether it dovetails with the information that the physician is going to find useful, if that is indeed the end game to sort of help the interaction. So having a discussion with your provider about what apps they like to use, can be very helpful if the provider is tuned into this whole digital health space. I think patients should be prepared in this transition period for the fact that a lot of docs aren't quite used to this yet. But the one thing I'll say, and you guys both know I feel this way, is that there's absolutely no doubt in my mind that this is the way we're going. Like, I think going forward, what's going to happen is that providers or health systems will choose applications that they're comfortable with and that ideally would interface with their electronic medical record. We'll be collecting data that way. It's really gonna open a whole new world to enabling patients and providers to communicate more effectively, because right now, let's be honest, oftentimes we're not on the same page.
Right. Yeah, absolutely. So we don't have a whole lot of time for our next session, but I just want to, we had some great comments about Lori Keefer's talk. And even like you said, she's the expert in this. But and now both of you use behavioral therapists within your university system. When do you consider sending a patient to a behavioral therapist? Just really quickly.
We will probably have comments, but it has to be someone who's open to
Mhm.
using and utilizing it for the management of their symptoms. They're not really open to using behavioral approaches like gut-directed hypnotherapy or cognitive behavioral therapy. That's not good. I think people that have stress-sensitive symptoms, so stress can trigger their symptoms, and then also people who can have some of these negative anticipatory anxiety thoughts of their symptoms, which is completely normal. But if they need some help in managing those thought processes that can negatively impact their symptoms, then I think behavioral therapy is helpful.
Yeah, I think Lynn summarized it really nicely. Just two additional points which I think are really key. One is the symptoms don't have to be severe for you to get better with behavioral therapy. It used to be that we as healthcare providers used to say that only patients with severe symptoms we should be referring for CBT, cognitive behavioral therapy, or gut-directed hypnosis. That's actually not true at all. Any level of symptoms, in fact, you could argue that patients with minor symptoms may do even better than patients with severe symptoms. And then the second thing is to build on something that Lynn said, stress-related symptoms, but insight into the association between the stress or anxiety and the patient's GI illness experience is really key. So having that component, but also having insight into the relationship really increases the likelihood that you're going to respond to behavioral therapies like CBT or gut-directed hypnosis.
Fantastic. And that's definitely something for you to talk to your healthcare provider about. Dr. Keefer had a bunch of resources in her slides about places where you can help to find someone who can help you with your behavioral therapy.